I'm thrilled for the opportunity to share a little bit more of some work that I conducted on behalf of myself and my colleagues. One of my colleagues, Clint, who is on the paper that I'm presenting, is here today, so I'm happy that we have some representation from the team. So today I'm going to be presenting AI for public health strategies, some high-level insights with GPT-4o, and why humans still matter, of course. So I'm Kelli DePriest. I'm a nurse researcher at RTI International. I lead research and program evaluations to understand how the conditions of people's lives shape their health, and I focus on turning evidence into actionable solutions. So, as a nurse, I'm grounded in caring for individuals and families, and as a researcher, I apply that lens at a systems level, connecting clients to solutions, evidence to practice, and ultimately people to better health. As I mentioned, I wanted to acknowledge the my co-authors for the article that I'm going to be presenting today. They're on the slide, including John, Kaylin, LaShawn, Clint, who is in attendance, Peter, Karen, and Rob. Quick funding disclosure. So this work was funded by CDC through a cooperative agreement with ASTO and NACCHO. RTI works on the project as a subcontractor to ASTO and NACCHO, and the content of the presentation is solely the responsibility of the authors and does not represent the official position of CDC. Also, reference to any specific commercial product, process, or service by trade name, trademark, manufacturer, or otherwise does not constitute an endorsement, a recommendation, or a favoring by CDC. So today, I'm going to open with a little bit of the motivation behind this work, why we pursued the study in the first place, then share a brief background, present the methods, really dive into the findings, and then present our implications or sort of our conclusions, and then hopefully open it up for a broader discussion to hear from the individuals on this call. So first, our motivation behind the work comes from two levels. So it aligns with RTI's mission, number one. RTI International is an independent scientific research institute dedicated to improving the human condition. Our organization has ongoing projects with a wide range of clients, including state and local health departments, nonprofit organizations, and the federal government. And our tagline is delivering the promise of science for global good. And to me, part of the promise of science is exploring new ways to conduct research and evaluation. So this project aligns with our mission, but the second level hits a little bit closer to home and is grounded in our experience. So for one of our rapid evaluation projects, we needed to quickly assess the scope and quality of strategic plans that were developed under a national public health initiative. As we worked through that task, we reflected on the value of strategic plans in public health. So there are tons of quotes that emphasize the importance of planning, but I like this one by Alan Lakin, which is planning is bringing the future into the present so that you can do something about it now. We also reflected on the volume of strategic plans. So we saw a potential opportunity for AI tools to help synthesize and compare plan content, which could help facilitate plan implementation, monitoring, and refinement over time, helping to support strategic public health action. And the final crucial motivator is that we worked with wonderful clients who were really willing and excited to collaborate on this work. So with that brief introduction to our motivation, let me dive further into the presentation. So as I noted, the main content, aside from the sort of like contextual factors of what really happened behind the scenes, but the main content is stemming from an article that we recently had published in the Journal of Public Health Management Practice. There is a link to the article on this slide as well as sort of the reference. I will note it's behind a paywall, so if you'd like me to send you a PDF of the article, feel free to send me an email. There's also a link to a JPHMP Direct blog post that we created to sort of present the results in maybe a little bit more accessible of a way, and that is publicly available. You can also find that on JPHMP Direct just by probably searching my name. I think it should come up. So now we're going to sort of dive into the meat here. So data-driven strategic plans, they're crucial tools in public health. I'm preaching to the choir, obviously, on this one, but they're great for fostering collaboration among diverse partners, and they serve as a compass guiding resource allocation and helping to prioritize health interventions. They're also a requirement to obtain and maintain national accreditation. State and community level health improvement plans outline agency goals, objectives, and strategies for promoting population health, and they're integral to public health practice and play a key role in achieving national health benchmarks, such as like Healthy People 2030. The plans, they vary in scope, format, and level of detail. We know that understanding the information in state and community level health improvement plans and related action plans is crucial for public health funders, practitioners, and evaluators to support plan implementation and progress monitoring. But the level of effort to perform content analysis or sort of manually reviewing and synthesizing key information across the plans can be a challenge. So, how do we balance the two? Well, we argued that efficient and accurate abstraction methods are needed to support ongoing improvement of public health initiatives. So that's where we enlisted the help of artificial intelligence. Why do we do this? Well, artificial intelligence, particularly large language models, offer promising semi-automation for reviewing strategic health plans. Large language models are a type of generative artificial intelligence focused on language-based tasks that could speed up content analysis. These tools retain human involvement while increasing efficiency by automating parts of the abstraction process. Despite its potential, AI adoption in public health can be limited by resource constraints and training needs. But we do want to note that adoption is changing just as quickly as AI, with increased access to popular AI tools among government agencies such as ChatGPT Gov from OpenAI. Given our understanding of AI, our study sought to investigate the use of a large language model to facilitate content analysis of real-world public health documents. The documents we used are called accelerator plans. So the CDC Social Determinants of Health Accelerator Plan Initiative was launched by the National Center for Chronic Disease Prevention and Health Promotion in 2021 to support multi-sector partnerships to make systemic changes to address social determinants of health. The initiative targets 5 critical domains affecting chronic diseases. They're shown on this slide. They include community clinical linkages, built environments, social connectedness, tobacco-free policy, and food and nutrition security. Since its launch, the program has empowered 71 recipients to create action plans to drive community health improvements. RTI was conducting an internal assessment of accelerator plans from recipients who were awarded funding from year 1 of the initiative, and we chose 4 of these plans to serve as a convenient sample for this analysis, mostly because they were publicly available, so that allowed for replication and avoided privacy concerns. Using the 4 plans as our sample, we asked the following 3 questions. So, how does data extraction using an LLM compare to manual extraction methods? How reliable and consistent is data extraction across plans? And what are the strengths and limitations of content analysis using a large language model versus manual data extraction by humans? The 4 plans we chose were publicly available accelerator plans written in 2022 by multi-sector community partnerships in Hawaii, Rhode Island, Portland, Oregon, and St. Louis County in Minnesota. We used OpenAI's ChatGPT Plus tier, which cost $20 a month to access. In July 2024, we were running the data analysis. We tried to use the free version of ChatGPT, but the context window wasn't large enough to compare all 4 plans in one prompt. So we had to sort of upgrade levels. And the underlying AI model we used was GPT-4o, and we just used sort of the out-of-the-box ChatGPT.com version. We were guided by methods used by Gartner and colleagues at RTI, and their methods included crafting initial prompts by drawing on some of the content from the instructions and specifications that the study lead gave to the study team analysts when they completed the human content analysis. We then iteratively refined the prompts using Rhode Island's plan because it had been double coded and it was the most comprehensive plan. We were careful to refine prompts using only one plan so we could explore the reliability of the prompts across the remaining 3 plans. If you're able to access the article, one of the online appendices, Appendix A, presents all the final prompts that we use for each data element for the individual plans. We selected 20 data elements to review, representing 4 distinct types of data. That included social determinants of health focus area, funder required sections such as a purpose statement and a work plan, the description of the priority population and leadership team, and page counts. We analyzed items for each individual plan. Then we wanted to see how well GPT-4o might synthesize results. So synthesis questions asked GPT-4o to perform a similar request to the individual plan questions, except across all 4 accelerator plans at once in a synthesized format. Accurate outputs to these questions could demonstrate whether GPT-4o is of additional value to public health entities who need to analyze, synthesize, and organize information across multiple multi-page documents. We individually uploaded each accelerator plan PDF as a new chat dialog and prompted the model for all the individual plan data elements using the same order for each of the 4 plans. And as I mentioned, the prompts are available. After this step, we compared the output from GPT-4o to the reference standard. So for our analysis, the study team analysis served as a reference standard, but was not without error, which you'll see in a couple slides. When there were discrepancies, we reviewed the plans to determine whether the error should be attributed to GPT-4o or the study team. Using an error description system developed by Gartner and colleagues, we classified data errors as either false or fabricated data, or missed or omitted data, which is when the data was present in the reference standard that were missed or omitted by GPT-4o. After the individual analysis, we uploaded all 4 at once and prompted the model for the synthesis data elements. So for the synthesis round, our unit of analysis consisted of individual data items. So if multiple errors occurred within the same data item, such as incorrectly identifying maybe 2 plans as having initiatives related to social connectedness, we counted that as one single error. Once we completed data extraction and analysis, the study team compared resources for each method by reviewing our timesheets and our calendars to estimate the hours for each step. We then met to reach a consensus on the total estimated time required. Now we're going to jump into the results. So for individual plans, the study team analysis was more accurate than GPT-4o analysis. You'll see on the slide, there's sort of a side-by-side comparison here. So the study team correctly identified 75 out of 80 data elements, and GPT-4o correctly identified 63 out of 80 data elements. For the errors, for the study team, the 5 errors were from missed or omitted data. So there was one case of missing an SDOH focus area from one plan, a few cases of missing an individual or a group from the description of the priority population and leadership team, and one instance where we were off by 1 page count on a plan, counting the pages. There were no false or fabricated data errors from the study team. Looking at GPT-4o, there were 9 errors. They included missing the description, missing 1 or more elements of the description of the priority population and leadership team, and being off on the page counts. Regarding false or fabricated data, there were 8 errors, and these were within the SDOH focus areas and the alignment with funding guidance section. So we can dive a little deeper into the GPT-4o findings on the next slide. So as we noted, the large language model was 79% accurate. We looked at each of the 4 types of data, so like the SDOH focus area, funder required sections, leadership and priority populations, and page counts, to sort of get a better sense of where GPT was performing well and where there were more errors. You can see that GPT-4o performed well extracting basic data elements, such as identifying which SDOH focus areas were included. GPT-4o also performed well identifying the presence of mission, vision, and the funder required sections, such as how plan strategies and outcomes would be measured, and whether or not there was a work plan with a timeline. As we noted on the previous slide, like the study team, GPT-4o had a lower accuracy, extracting more ambiguous data elements like the priority population and members of the leadership team. And then finally, GPT-4o had the lowest accuracy, extracting page counts, potentially because of variation in including page numbers for all sections or in sort of descriptions and how page numbers were included in the table of contents. Now, looking at the synthesis analysis, GPT-4o had an accuracy rate of 50%. So like the extraction for the individual plans, for synthesis prompts, GPT-4o missed data in the priority population and leadership team sections. And GPT-4o also fabricated data within all 3 of the synthesis sections. So those were SDOH focus area, alignment with funding guidance, and the description of the priority population and leadership team. We also noted that the errors in the synthesis analysis largely occurred in data points that were different than those in individual plan extraction. So one example here, during individual prompts, GPT-4o incorrectly identified that the plan from Hawaii had a community and clinical linkages SDOH focus area, but for the synthesis prompt, Portland was incorrectly noted as having one. So we found it interesting that the types of errors were not consistent between the individual and the synthesis analysis. As far as the resources required, GPT-4o required less time, but savings start to diminish when you account for the time for prompt development and then quality checks. So the study team abstraction of 4 plans took approximately 40 hours across 4 team members, and drafting, testing, and refining GPT-4o prompts on 1 plan, running the prompts, and additional refinement and correction required approximately 18 hours. We did note, though, once the prompts were finalized, GPT-4 abstraction took approximately 5 minutes per plan, might have been even faster than that. So, what are the implications for this work? Public health practitioners using AI tools should exercise cautious curiosity. So, GPT-4o is a promising tool for basic or well-defined data extraction from multiple complex SDOH plans designed to promote public health. Insights from this experience can inform broader public health planning to assist state and local health departments in obtaining a high-level picture of multiple jurisdictions. But using GPT-4o for this purpose requires well-designed prompts and careful output review. While GPT-4o can save time and resources in analyzing public health documents, depending on how much error researchers and practitioners are comfortable accepting, users must remain aware of its experimental nature and supervise its use to mitigate risks and errors. So I see there are a couple of questions in the chat. I wanted to provide my email. I know we're going to jump into a discussion, but if you have any questions or feedback or any thoughts on areas where you might like to collaborate or sort of talk further, please feel free to send me an email or find me on LinkedIn. I'm also happy to connect at APHA. So yeah, I'm going to take down my slides now so I can maybe peek at some of the questions, and Andrea, I might throw it back to you for the discussion if that's okay.
Yes. All right. Let me stop the recording.
Thanks.